screen, you perfect, and you only see my slides and not anything else, right?
Yes.
Perfect.
Good to
Okay,
go.
good. All right, good to go. All right. Thank you for the introduction. All right, we're going to be talking about depressive disorders in children and adolescents today, and I made way too many slides, so we probably won't cover everything, but I'm hoping to hit on all the big points, and if there are things you need to reference, you can always go back and do that if you have the slides. I don't have any disclosures, but let's just jump into it since there is so much information. So, epidemiology. Depressive disorders are common in kids and youth. Depressive disorders become increasingly more common as kids get older and become adolescents. So, like rates of anxiety and behavioral disorders are more common in general, but we see those more in younger kids, whereas depressive disorders start to spike up, the occurrence start to spike up in older kids. So in teenage years, girls outnumber boys 2 to 1 for diagnosis of depressive disorders. And then overall, the hard thing is that every place I looked had slightly different numbers about the actual prevalence of depression in kids. What I generally averaged it out to and found was that 10%, pretty much 10% of youth had a depressive disorder. That's what they qualified for one. And then that was before the pandemic. Now, after the pandemic, it shot up to about 20%. So it doubled, which I think probably a lot of us sort of sense at a gut level, but the numbers support it as well. Now, some of the other interesting numbers that I think we should touch on is that among adolescents, 12 to 17, there's some reports from 2018 to 2019. It says here 15% had a major depressive episode. And then you can see one number I think is scary is 18.8% seriously considered attempting suicide. So we could do a whole lecture series on suicide, honestly, because it's such a big thing. But we do have to talk about it a little bit, even though not a ton today, because it's one of the most, if not the most serious consequence that we worry about with depression. Now, you can see here this little graphic about there being 60% of kids with depression did not get treatment in the past year. So I've seen various numbers of that as well reported. This was posted, I think, this year. So this would have been to 2022, 2021. Now, like I said, different numbers out there, but what's interesting is that, or what's bad is that going into the pandemic, we already had a lack of child psych resources. We had a lack of mental health resources for everyone and especially for kids. So we were already struggling. There was already a mental health crisis growing. And then now the pandemic comes, and yeah, it added a few extra services, maybe here and there, like the 988 line for suicide crisis intervention, or some telepsych is now more approved. But overall, we have not even begun to make up for the gap that we had in services prior to the pandemic. Then when you look at mental health disorders doubling in kids, so depression, but all in general, mental health disorders doubled, we hardly have anything to cover that then. So it kind of makes sense to me that even though we're trying, 60% of people with depression didn't get treatment. Again, back to suicide. So this is a chart that shows the leading causes of death in age groups. Now, for a long time, most of the time, suicide has been a top 3 cause of death in kids, in teens and kids. It sometimes varies second, third, but it's always in the top 3. So you can see here the green boxes are suicide. So you can see 10 to 14, it was the second one, 15 up was the third one. This was from 2020. So it is something that we need to worry about with our young people. One thing that really scares me, and I think is important to talk about because it can change our practice, is that the causes of, or the way of dying for suicide has gotten a lot more violent. So you can see here in 2020, cause of suicide by firearm shot up, and was half of the ways people died by suicide. This is actually for all people, so this includes adults, but they have noticed the same trend in kids and teenagers mirroring this. So it's almost like half firearm, which is really, really scary. So, and used to be that men were 3 times more likely to actually die by suicide than women, and they're way more likely to use violent means, so something like a firearm. But now the gap is closing, and there are many more women and girls doing this. One more thing that I think we need to touch on, and I don't know what to make of this when I'm being totally honest, but I do think it's important. We have to think about it somehow because we're in this crisis, is that this is the crazy thing. During the pandemic, suicidal ideation went up, mental health disorders went up, but actual suicide rates dropped. So that's kind of interesting. The problem was that when kids went back to school, the rates shot back up again. So suicide rates went up 12 to 15%, completed suicide in teenagers went up 12 to 15% when kids went back to school. There's a lot of discussion of why is this? We don't really know. There are a lot of theories out there, but what has been known for a long time is that school actually is a part of this epidemic, this suicide aspect, not just with the pandemic. You can see here, this is a graph that I thought was very interesting and scary. What they did was they looked at suicides in kids from the past 10 years, I think I'm blocking it, but like 2010 to 2020. So even before the pandemic, and they looked at when kids were more likely to commit suicide. And you can see here, it's during the school months. So the summer, way, way less likely. Friday, Saturday, Sunday, way less likely. When do we see a really big uptick? Mondays and Tuesdays. So the idea of hating Mondays, it's real. Like it, really worse things do happen on Mondays. And I'm sure there are lots of different reasons for that. And I'm not saying that we need to blame the school or anything. If anything, it's the opposite. We need to help people in school, the teachers, the staff, the kids, because clearly there is some component there that is going on. All right, going into etiology. So the single most predictive factor associated with risk of developing major depressive disorder is a high family loading. Heritability for MDD is 40%. Now, a lot of parents will ask, okay, is it genetic? And the answer is always yes and no. It is. But there's a genetic predisposition. Often people have a genetic predisposition, but it takes something to activate the disorder. So that's what I tell parents. And we usually can't pinpoint that one thing. It's not just because they, experienced one trauma or they experienced a loss or they had a bad day. It really depends, and it's usually multifactorial. So we can look for reasons, but it usually doesn't help a ton. The clinical course of major depressive disorder in kids is, they found when we looked at the studies, the median duration was about 8 months that it lasted for. So not horrible, not great. Recovery by 2 years was significantly more likely for those who were short-term treatment responders than for others. And slightly fewer than half of the recovered adolescents experienced a recurrence by 5 years after baseline. So the good news is that it can get better. The bad news is that it doesn't always, and it's easy for it to come back. All right, let's jump into evaluation of depression. Sorry, this is a very busy slide. So what I put on here are screeners for depression, essentially. These are free screeners for the most part. So the thing I left off were like the kind of things that they do in psychology, where they have these beautiful tests looking at like mood disorders and depression, and they pay for them and they're scored by these excellent psychologists. I left that off here because I figure we're not going to teach you how to do that necessarily, but they do exist. So these are some free available ones. The one that I use most commonly is the PHQ-9. It's for 12 plus. I do sometimes use the PHQ-A. The nice thing is that it's for ages 18 and up, or excuse me, 11 and up. So I will use that with 11-year-olds, but otherwise I tend to do I don't do a ton of screeners because my whole job is to talk to people about psychiatric stuff. So for me, I tend to do all the stuff in the interview and I don't need to screen because I'm actually screening with my interview. I put also here on the side the preschool feelings checklist for little kids if you're interested. Now, I picked this quote out from a paper. You don't have to read the whole paper, but I liked the quote. The reporting of depressive symptoms on a screening measure should trigger a clinic-based conversation with the patient to determine the most appropriate intervention rather than an automatic referral for specialized psychiatric care. I'm not trying to say you can't refer people to psychiatry. All I want to say is that a screener is just that. It's a screener. It's not a diagnostic tool. So it's important that you, if things come back with a positive screener, that you investigate it a little bit more or try and figure it out. It doesn't just mean because it's pan positive or pan negative that that person does or doesn't have something. One thing that I liked on here, this little blurb of screening tools, I love the screening tool. Do you feel depressed? It is a 1-question screening tool. There's actually research on it. It has mixed data, but it actually has pretty good data considering it's 1 question. So just saying, do you feel depressed can actually be pretty sensitive for screening. Now with kids, the one difference that the studies say is that you have to ask, or you have to listen to the answer. And if it's yes, okay, yes, then you go more into screening. Or if it's I don't know. They found that I don't know equals yes. It means you need to investigate more. The only time when we know something is if they say no, you don't have to follow up a ton more. Now, this may not apply to like a 6-year-old, but for our teens, it's actually pretty good. So if you just have 4 seconds, asking if you feel depressed, it's a pretty good one. This is something I originally had like roughly 10,000 slides on, I think, and then I cut them down. There are developmental aspects with depressive disorders in kids. They look a little bit different depending on the age. So the most common thing in general is that irritability is much more common with anxiety and depression in kids than in adults. So if a kid is getting really irritable and snapping, that might be depression. A depression might be one of the differentials, basically. You can see on here, sorry, it's a bit blurry, this little chart, and it's not perfect. Certainly some kids can have different symptoms, but it makes sense. Preschool, school age, you see more acting out, more irritability, somatic complaints, because they can't express themselves that well, right? But then you look at an adolescent, and maybe there is less energy. So a little kid with depression might not lose their energy, but an older kid might. Just something to keep in mind. Now, I love this chart. I was trying to figure out multiple ways to put this chart in here. But part of it is we have to monitor for when sad feelings or sadness, low mood turns into depression. So the part of the reason that I put this in here right now is that when we see kids developmentally, we're seeing them at a snapshot in time in our office, especially kids and less so adults, but if we see a kid who seems sad, maybe they're in this, you can see this little adjustment disorder area where they have some tearfulness, maybe a grandparent just died and they are having more tantrums at school. And, the teacher's like, the family's like, is this a disorder? Well, if it's not that many symptoms, maybe at this point we're seeing it as an adjustment disorder. Now, let's say that's what you see in the primary care office. And sometimes the primary care doctor or other people will say something like, it's not depression, it is an adjustment disorder. Parents don't always understand that we see things changing with kids, that it's a fluid process. So sometimes by the time they get to me, they do have depression. So I say they have depression and they say, well, but depression's been ruled out. To which I say, it wasn't depression before, but it may be now. So we are seeing kids as things are developing. So it's not just a simple question of, is it this, yes or no? Yes, we have to do that too. But it's what is this turning into? What are we trying to prevent? So when does it become a disorder, right? When it is persistent, severe, causes impaired functioning and or subjective with significant distress. We're going to go into the different disorders. Now, I'm going to touch more on some than others just for the sake of time. One thing that I really wanted to point out that I made a whole special slide for is after I read everything, after I did all this research, I changed my goals for this lecture. So in my mind, and as a psychiatrist, initially what I was thinking is, if PCPs or primary care doctors of any sort just know what depression is, that's really good enough. It's the specialists that need to know all the different types, like, psychotic or melancholic, because that's our specialty, right? But as I was reading it, I realized that the big gap in care oftentimes comes from PCPs or other providers not knowing the appropriate recommended treatment with the severity of depression. So what we do is we score depression, mild, moderate, or severe. And it's almost like a judgment call to some degree. But the thing is, the treatment guidelines are based on that mild, moderate, or severe. So knowing how you should treat, it's just like if cholesterol is over a certain number, you treat it this way. If it's under a certain number, you treat it this way. That's the same thing with depression. But I found that a lot of times people don't do this in sort of primary care practices, knowing the mild, moderate, or severe. And I didn't think it was a big deal until I read all the gaps in care, and I will get to that later. So I would recommend going forward from here that you try and calibrate mild, moderate, and severe depression with what it looks like clinically, like what you think it is, how it applies to kids you're seeing. You know, if they've seen a psychiatrist and the psychiatrist calls it moderate, try and figure out, like, do you feel like it's moderate? So try and calibrate it so that you are in sync with the research and treatment guidelines. Now, it's not perfect. What some people call mild, some other people might call moderate, but it's usually within one deviation. You know, like if I call it mild, usually you're not going to call it severe, or vice versa. If this person's trying to kill themselves every day and I'm like, that's severe, chances are you won't call it mild. So just getting a sense of those different categories. All right, so let's jump into the different disorders. That was my 2 cents that I wanted you to think about as we go forward. So major depressive disorder, that's the big one, right, of depressive disorders. I'm not going to go into the criteria too much, but basically we need 5 out of 9 of the depression criteria to call it MDD. Now, a couple of things that I want to point out. Yes, you should always go back and check on the criteria, because I'm not going to this is not teaching you the exact criteria of everything. I just want to give you some pointers for when you see these disorders, how to recognize them, and what you should think. So major depressive disorder comes in many flavors: mild, moderate, severe, psychotic features, single, recurrent, atypical, typical. Like I said, I think you need to know the mild, moderate, severe personally. One thing that catches me off guard sometimes is that parents often call sadness or low mood depression. So I'll say, are they depressed? And they say, oh yeah, yesterday they were really depressed because I took the toy away. And we mean different things. So I have to investigate what they mean. Often I will describe for them what I see a depressive episode is just quickly. Like I'll be like, hey, have they ever been depressed? And by depression, I mean, at least like several days where they don't want to do anything, or they're really down, or they're crying more. They just seem like not themselves. I'll go on a bunch of symptoms, but the big thing is that it's more than a day. And that usually clarifies a little bit more. When we talk about either an impairment in functioning or distress, that's either criteria, or they can have both. The impairment in functioning comes down to the developmental aspect. So a little kid, their impairment in functioning is going to be they're not playing as much. Maybe a teenager might be they're isolating more. So it's based on their developmental stage. Now, I ask lots of details about suicidal ideation. I usually, in an evaluation, a psychiatric evaluation, I ask all these questions, but especially if there is a new diagnosis of depression or anything, I will still ask all of these questions again. So for suicidal ideation, I treat it just like it's any other symptom, like, acid reflux or whatever. You want to know, when did it start? How often does it occur? How often does it last? What triggers it? What makes it go away? Is it active or passive? I can tell a lot of people aren't often asked this by the time they come to me for an evaluation, because they always look a little puzzled, and I have to re-explain, like, okay, so what makes it go away? And they're like, I don't know. So I have to press a lot. I would recommend that you ask about suicide, and beyond that, you ask all about it. So back to this mild, moderate, severe topic. So I was trying to look for like really good criteria. So I was like, I got to teach them about mild, moderate, severe. There has to be very specific criteria. There's not. I was hoping there would be. So basically, mild depression is like some of the symptoms and not as severe and not as much of a functional impairment. Moderate is basically more. Severe is the most. So it is a bit of a gut instinct. What I would say is usually it's easy to tell the mild and the severe. The people that are trying to kill themselves every day, they're not getting out of bed, they're not going to school, they're not going to work. Severe, right? Mild might be like, oh, I think this kid's depressed, they're having problems, but I don't know what I should do about it yet. That's probably a mild depression. But again, it's good for you to try and calibrate based on your clinic population, so you get used to picking out the worst versus the not worst. The PHQ-9 also rates things in terms of mild, moderate, and severe depression, so that can kind of help you calibrate as well. All right, let's get into bipolar disorder. So bipolar disorder, I'm only bringing it up to tell you why I'm not going to bring it up. I know a lot of people would expect me to talk about bipolar disorder because it used to be in the mood disorders category with depressions in the DSM. It is not anymore. It is separate from depressive disorders. So that was my trick. If you thought we were going to talk about bipolar disorder, then you don't know the newest DSM categories, which I sort of didn't either. But anyway, it's in its own category now. So it's not listed as a depressive disorder. This is the reason why I want to talk about it. It's because it's controversial in child psych, if I'm being totally honest. It's not controversial that it exists. It's controversial in who actually has it. So there are two main schools of thought in child psychiatry. They're the people who think bipolar disorder is underdiagnosed in youth and we're not calling it. And then there are people who think it's overdiagnosed and doesn't really exist. And by that, I mean kids under 16. So if we're talking about a 5-year-old. And the thing is, both schools of thought have pretty good research to back up both things that they believe. And what it is it's usually a collection of symptoms that we're calling things differently. So I come from the school of it probably doesn't exist that much in young kids. It's probably something else. It's usually some combination of dysregulation, impulsivity, high energy, and difficulty with attention. Now, is that bipolar disorder or is that ADHD plus depression plus, other things? I don't know. The way I see it is it's usually multiple things and not a true bipolar disorder. What I would recommend is that if you're going to make the diagnosis, well, first of all, I'd say if you're a PCP and it's a kid under 16, I would not make it if I were you. I just wouldn't touch it. Call it what, like say dysregulation, but I would not call it bipolar disorder because we have not figured out what we're doing with it in child psychiatry, to be totally honest. And that's what I tell parents too. So, and if you do decide you're going to call it, I hope you are someone who has seen what a true manic episode looks like. And you're like, whoa. So it helps. Like I was, when I was a resident and I was on the adult unit, and we had people who were manic, who were dancing in the hallway in the middle of the night naked, like grown people doing that. I got to see what mania looked like in a way that I had not expected. Now that's mania. Everything else, I don't know. For the kid who's like kind of irritable and changes, they change what they like and stuff all the time. Is that bipolar disorder or is that just a bunch of other stuff going on? So I tend to go with the bunch of other stuff going on. And there is a reason for that. So part of it, if you ever want to look back, I think this is a good example of a low-key bipolar manic episode happening, but on film. But the thing is, if you want to call it bipolar disorder, if you see it and you're like, this kid's all over the place, or the parent uses the term bipolar disorder, what you really need to screen for is disruptive mood dysregulation disorder. Now, DMDD is interesting because it was created and first seen in the DSM-5. So our amazing psychiatry book, it just came out in the latest edition. And the reason it was created partially is because we could not agree on bipolar disorder in kids as a community. And what happened was they did a bunch of studies and they found longitudinally long-term kids who were diagnosed with bipolar disorder did not meet criteria when they were adults. And it's not something like that. That shouldn't happen. It's like your eye color, it sticks with you. It should not change. So what they found was that bipolar disorder probably does exist in some young people, but we are not good at picking it out. We don't know who's going to actually have it. But there was a subset of kids that they look, for better words, bipolar because they're super dysregulated. They're all over the place. They cannot keep it together. They are just emotionally intense. What do we call those kids? And we realized we didn't really have a name for them, but they existed. So that's how we came up with DMDD, disruptive mood dysregulation disorder. That's basically, it's not saying they're going to have bipolar disorder. They may not. They might have generalized anxiety disorder. Who knows? But they are their own disorder. Like it exists, And so this helps us so that we don't have to make bipolar disorder in a dysregulated 10-year-old as a diagnosis. Now, the thing to know about DMDD is that also, since it's new, they're still researching it, right? They found that it exists, but the research is still ongoing. Basically, if you diagnose DMDD, you cannot also diagnose ODD. You can't do them together because they found that the kids who meet criteria for DMDD, they all meet criteria for ODD. So it's like a trump card. Now, as they're doing research, they're finding there's sort of different domains of ODD and DMDD, like one's a little bit more of a mood thing and one more behavioral. So I wouldn't be surprised if in the next edition, they might make it so that DMDD can co-occur with ODD, but as of now, it can't. The differences too are that DMDD has to happen in two environments. So like with ODD, only one environment. DMDD is two, but one can be less severe. So basically a kid who has a ton of tantrums at home, they have to have some problems at school or out with their friends for it to qualify for DMDD, because these are kids that are so dysregulated, they cannot keep it together. They just can't, like they just fall apart. And so you can imagine that's why it bleeds into, it can't just be only home or only school. It's more than that. So it's technically for the criteria, 3 outbursts or more a week, like inappropriate anger. And then it's between ages 6 and 18. Its symptoms are usually by age 10. So if you see a 5-year-old who's real dysregulated, you cannot call them DMDD, but you can worry about it in the future. All right, going into persistent depressive disorder. So persistent depressive disorder, previously known as dysthymia. There is technically still a dysthymia component. I'm going to ignore that for now, but persistent depressive disorder is basically your ongoing depressive symptoms for 2 years or more. And they're usually more mild, but they're just ongoing. I put on here, I think Eeyore is the perfect example of that. The PDD is more likely to get diagnosed like later teens or adults because they have to have had depression for a couple of years. But, you know, it still can happen earlier. It's less intense, but what you run the risk of is there's something called double depression. And it's more likely to happen in this population. So people with PDD are more likely to get an acute MDD, which sucks because they're already depressed and now they're more acutely depressed. And that's when it gets a little bit more dangerous. So these are kids that the way I think of them is they're usually a little bit more cynical, dysphoric. Whenever I see a cynical 13-year-old, a lot of times PDD is one of the underlying things because they've dealt with depression for part of their childhood. And what makes it dangerous, like I said, is then they get an acute depression on top of it. They already were unhappy in life and now they're even more depressed. So usually when I make the diagnosis of PDD, it's that's not why they were referred, but it's on top of other diagnoses. So this is the kid that's been dealing with depression for a long time, like low level, and now something happened and it's worse. All right, PMDD. All these acronyms. So premenstrual dysphoric disorder. I'm not going to go too far into it, but what I will tell you is that it's basically way more intense PMS. So it's way beyond there. It is symptoms that happen around the time of a female cycle. So like a severe mood symptoms. Now, I don't usually diagnose this. Actually, I found it's more diagnosed in like primary care and OB-GYN. Usually when people come to me, they have a menstrual component, like they have a component around their periods, but they have other stuff too. So they have a major depressive disorder that then gets worse around their period. That can happen. That's usually what I see because it's gotten to the stage that they send them to a psychiatrist. The thing with that is it's still treated the same way. But what you should know is that if you do suspect PMDD, is you should also screen for just general depression and suicidal ideation. So maybe it comes up while they're talking about their period, but you should see if they have an overall MDD or suicidal thoughts, because there are chances that it's a good chance that this is flying with other disorders. Now, what's interesting is that you're supposed to track your period for 2 months to get to qualify for this disorder, right? So I put this little blurb in here. We don't need to go into it. I'm a huge fan of apps. Like I am, and I know we all love apps, but the problem is, I don't know why this is, but it is a very lucrative business for companies to sell period information. Super weird. But they have come out showing that companies that like apps that track periods and pregnancy stuff, they sell the data like crazy. And there's some suspicions that it might be used for life insurance, things like that. So normally I'm a big fan of period apps, of apps, but not with periods. I don't ever tell kids to do that. All right, and then we're going to touch on the last 4 disorders in this one tiny slide. These are ones I don't make a ton. I would say of all the diagnoses I make, probably major depressive disorder is number 1 of the depressive disorders, but MDD, and then probably DMDD, and then unspecified depressive disorder. You can see on here. Those are for the kids that you're like, yeah, they have depression, but it doesn't quite fit or it's not quite enough. So we want to call it something. We need a placeholder, but haven't quite figured it out. So this is my 3rd one that I use the most. The other ones I hardly ever use. Maybe I should, I don't know. Substance induced or medication induced depressive disorder. The important thing is it just is because of the substance, and the symptoms can go on for a month after even stopping. So this is really within the context of a certain thing. I imagine they would see this more in like, well, maybe substance use disorders, but also in like cancer maybe, or things where they put you on medications that might really mess with your mood. And normally you don't have any psychiatric concerns. Other specified depressive disorder, they have lots of little ones like recurrent brief depression, depressive disorder with insufficient symptoms. I used to try and fit things into this category because honestly, when I do see things that I'm not quite sure if it's MDD, often they do, but honestly, I usually just go with unspecified depressive disorder so I can try and figure out what's going on. I would recommend that unless you know for sure it fits into one of those categories. And then depressive disorder secondary to another medical condition. The important thing to know is that it's for people who medical stuff has messed with their brains for the most part, and so now they're down. So strokes, Parkinson's, Huntington's, traumatic brain injury maybe. When we compare the depressive disorders, you can see they're a little bit different. We expect some things more than others, but we still see the main symptoms of depression. Now let's get into treatment since okay, good, I'm flying through this. Sorry it's so fast, but I want to make sure I get into treatment. All right, back to that mild, moderate, severe thing I keep harping on. Why do I want you to know that? Why did I change my mind so much? It's because this paper showed that, and this was 2014, okay, so maybe things have changed, although they showed during the pandemic actually evaluating for depression in primary care offices went down a lot. I'm assuming because there's other stuff going on, but so I wouldn't be surprised if this was still an accurate number. But that being said, so they found that few PCPs recommended an antidepressant in general for depression. So you can see 25% recommended them for moderate depression, 32% for severe depression. Compared with treatment recommendations for moderate depression, severe depression was associated with greater likelihood of child psychiatry referral. Depression severity did not affect the likelihood of antidepressant recommendation. Antidepressants were more likely to be recommended by PCPs with greater depression knowledge. I hope that will be you if you're here today, or an access to an on-site mental health provider. Now, why do we have to know this? It's because a lot of PCPs are like, should we, or anyone, should we start an SSRI? Should we not? It feels very like vague and what do we do? But actually they're guidelines. That's the crazy thing. Just like cholesterol, just like, blood pressure, when you start a statin, when you don't. So it's the same thing for depression medication. Now you can still talk to the parent. They can still say no. You can come up with different things, but the research is pretty unequivocal about when it recommends therapy and medication. So that's why I think it's weird, or it's worrisome that people don't know the mild, moderate, or severe thing, or that they're different. I think you have to know that to then know what the treatment guidelines are. So we're going to go into the studies a little. I know this is so much information. The main things I want to tell you, I'm going to skip ahead. So we have 3 big studies in child psychiatry on depression. They're very good, for child psychiatry, that is, but they're double-blinded and, independent interview, like lots of good stuff. They're very well done. And it's very hard to get that in psychiatry because there's so many problems. We have 3 big depression studies for medications and therapy in teens that tell us what we want to do. Now there's still information coming out, but these are the main ones, right? The TAD study, the Tordia study, and the ADAPT study. If you ever want to go back and look at the individual things, they're pretty interesting. I tried to sum up important stuff, but I will go into the big points. So if you get time, I would recommend you look at these big therapy points and these big medication points, but I don't want to go into them too long today. So I'm going to skip over them, but I will sum them up even more in a next, even more summary slide. The big takeaways from those big studies that we did: for moderate and severe depression, meds and therapy are the most effective, like hands down, pretty much. It was a little different when it got to be the most severe depression. The weird thing with that is that medication or meds plus therapy were equally as effective. So for the most severe depression, they found that therapy wasn't as effective. It didn't make a difference and only cost more. That being said, we all know that therapy is good. And one of the reasons therapy is good in these studies is, so the medication is associated with improving depression. Therapy, they teased out, it's a little bit more associated with reducing suicidal thoughts. So it's always good to do it in combination. That being said, you don't have to feel bad if you have a kid who's really depressed and on a med and won't see a therapist. Yes, it would be good, but the studies show that it has equal efficacy. That being said, when in doubt, moderate, severe depression, do both. Or at least recommend both to the family, because that's what's going to be the most effective. Then if kids fail one SSRI, all the data shows, and all these studies show, you can either switch to another SSRI or you can switch to venlafaxine. So venlafaxine is an SNRI. Both are equally as effective. What they found was basically half of all depression was, I think it's more than half of all depression was stopped when with the first SSRI. So most kids actually respond and do great. Of that half that didn't respond, half of those then responded to the next one, like an SSRI or venlafaxine. So very often we actually can fix depression or treat depression with one or two medicines, and we don't like have to jump to 1,000. Yes, sometimes we do, but the research shows that it's really effective. The only problem is, so at the second change, or at the first change from the first one, you can choose venlafaxine or another antidepressant. They're equally as effective, but venlafaxine was associated with more side effects. So why would you choose it? Maybe because people in the family have done well on it, or maybe you want to maximize some side effect of some sort. Other big takeaways. This was from an editorial that I liked. Perhaps the most important thing in improving outcomes for teen depression is to make sure that teens get to the clinic and get there early in their course of illness. There's been a lot of public chatter about how antidepressants are not effective or are harmful for teens, and that may be keeping teens and their families away from treatment. Investigator-initiated studies such as Tordia, ADAPT, and TADS are unequivocally clear that treatment for teen depression that includes medication is effective and can be implemented safely. So hopefully, if we broadly disseminate this, we can have improved outcomes for teens. All right, so when should we consider meds? Again, I just told you moderate to severe, right? That's when you should do it. And I'm not saying you have to force meds, but when should we prescribe them appropriately? When should we bring them up? Moderate to severe depression. Mild depression, you can kind of kick the can and say therapy first or lifestyle changes, whatever. But once they get into that moderate to severe, it's better to treat. And part of the reason is the longer depression goes on, the longer it's untreated, the worse it gets, and the worse the outcome, and it gets less likely that a medication will treat that. It's like having a chronic disorder versus an acute one. So, and it's multifactorial. I'm sure it's the neurotransmitters, but it's also if a kid's been hopeless for 3 years, they may not bounce right back with a medication. So early responders, people who respond to the first medication, like, it's better to try and get that in the beginning, get them to feel better sooner. And you know what? Not only will they feel better sooner, but they will see that treatment can happen. They will feel more hopeful. So I'm pretty aggressive with my treatment of depression. Now, what medications do we use? We can use pretty much all the SSRIs except for Paxil. Don't use Paxil. And they're approved mostly starting at age 7, with some of them at 8, and then sertraline's at 6. That being said, yes, we prescribe them sometimes to younger kids, but I'm not going to get into that in this talk just because of time. Okay, I know this is also a busy slide. How do we dose it? So see over here on the left, it says the recommended initial dose. What I would say is if you have a younger kid or who's sensitive or is afraid of meds or has mild symptoms, start on the lower end and go slow. If you have a kid who's older, who's not sensitive to meds, who is more severe, start on the higher end of the initial dose. If I see a slightly depressed 7-year-old or 8-year-old, 9-year-old, I'm going to start them on, Lexapro 5. If I see a 16-year-old who's severely depressed, I'm definitely going to start on Prozac 20 and not 5. So that's sort of how I figure out the dosing. It's a little bit of art in addition to science. I also, this is one thing I want to point out. I do a lot of shared decision making. So a lot of times people, if they ask me psychiatric things, they're like, okay, should we start high and then do this, or should we start low and then do this? And I say, ask the parents that, because that's what I do. So I will tell parents, we can start low and go slow, less likely chance for side effects, but more chance things will take longer and we may need to go up on it. Or we can start a little higher, still safe, but more chance of side effects, but more chance that it'll kick in sooner and be effective sooner. What do you prefer? I ask the kid and the parent, and they usually pretty quickly have their decision. I would say they almost all they very easily are like, yep, nope, we need to get it started. Let's do a higher dose. Or, I don't want to deal with side effects, lower dose. And then they know how you're thinking. What about when the first medication doesn't work? Okay. So first of all, if the first medication doesn't work, you should not leave them on it for like a year. It doesn't work like that. If it's going to work, it's going to work within a couple months. So the child doesn't have a clear response to the medication. It says here around 40%. Sometimes I do a little lower. Reduction in symptoms after 6 weeks, a switch should be considered. So you should not have kids that are like languishing on SSRIs for forever, hoping they'll work. It's pointless. What you want to do is, I put the examples in here. If it helps a little bit, you can essentially talk to the family. So if you see them at 6 weeks and they're like, it's kind of helpful, I don't know, maybe try going up on it once. Or if it's getting really severe, they don't really think it's helpful, maybe you want to switch. That's like a shared decision-making situation. We could do either. What about if they come back and it's like 40% improvement, they're surprised, things are good, but it's not covering all the symptoms? Yep, go up. They come back and they're like, I don't really think I've seen anything after 6 weeks. Don't increase it. Go to another one. That's fine. So it's sort of the you have to find the porridge that's, not too hot, not too cool. And that's how I tend to do it. Now, how about making the switch? There are a couple different ways to do that. The main ways are either direct, so stop one, start another, or cross taper. This is, again, more of an art. I do it a lot based on what the patient can tolerate. So if they're on really low doses of stuff, they haven't had problems, it's just not working, I will stop one and start the other. So stop Prozac 20, start sertraline 50 the next day. That's fine. If they're on higher doses, then I tend to do half the dose by a week. So they're on, I don't know, Prozac 60, and I want to get them to sertraline 100 or 150 or something, 150. Then I might go to Prozac 40, and then sertraline 50, and then Prozac 20, and then sertraline 100. So I tend to do doses based on the week. The more sensitive they are, the more freaked out about symptoms they are, go slower. Doesn't hurt. Usually these doses are low enough that you're not going to cause serotonin syndrome by adding another one at the same time. Like, very rarely. I'm sure there's some people out there who are predisposed to it, but you generally don't have to worry about it. So if you're like, oh no, should I stop this because they're already on Prozac 20? It's fine. Like, for most kids, now it's different if this is an adult who's on 30 medications that's affecting their system and their metabolism is slow. Yeah, then you have to worry about that stuff a little bit more. But kids, oh my God, they're fine. All right, what do we usually use? Fluoxetine, sertraline, and Lexapro, escitalopram. So I use all of these, honestly. People ask which one I start with. The way I start it is I see if anyone in the family has had a good response or a bad response to one of them. I'd say it works 50% of the time, or if they have certain feelings about them. The parents that are like, oh my God, my friend's kid got so depressed on Prozac, I don't want to do that. That's fine. Go with sertraline and Lexapro. The nice thing is they also all come in liquid. Insurance doesn't always want to approve it first, but they will. Sertraline has no taste. Lexapro or escitalopram tastes like banana. So if you kid that doesn't like banana, then don't do that one for liquid. And Prozac tastes really gross, is what I've heard as a liquid. This is the one that's contraindicated. Don't do Paxil. So the black box warning, we'll talk about that, but that's about suicidal thoughts, not about suicide risk. Paxil is the only one in kids that's been shown to actually directly correlate to suicide. Don't do that. You can continue it if someone's already on it, but don't start it. Don't be the one to start it in kids. All right, and then the black box warning, which I just kind of referred to. SSRIs, yes, so SSRIs can increase suicidal ideation in kids. The previous studies are old, and they've shown that the suicidal ideation went up by like 1 to 2% in the population. And there was not an increase in gestures. There's not an increase in actual attempts. No one actually killed themselves more. It's just the thoughts. So I always make sure to tell parents this. It's not, first of all, it doesn't happen that much. Second of all, it doesn't mean they're going to kill themselves. The data is quite clear that if anything, SSRIs are protective against suicide. So they might have more thoughts in the beginning. That's it. Now, I think it's important to tell parents that so that they know, yeah, okay, if they have suicidal thoughts, they come to you, stop the medicine, try something else. We don't know why it happens. They actually, there's been a lot of debate in the psychiatric community and research and stuff about if they should take away the FDA warning. When the FDA warning about that came on, use of antidepressants just dropped hardcore, and suicide in teens went way up, statistically up, like at the same time. So they found that people got freaked out about prescribing antidepressants, and then all this suicide started happening. And it's because usually if you have a kid who might kill themselves, the risk of some thoughts is much less dangerous than them actually killing themselves. So it's better to treat the depression. I know we all like get scared about psychiatric medication and what it means and stuff, but at the end of the day, it's pros and cons. Is this child potentially going to kill themselves? Then maybe we should push for the medicine more. Some things you have to worry about. Most common things: headaches, stomach aches, weight gain, sleepiness. Behavioral activation I see with younger kids usually. I warn parents of young kids. So behavioral activation happens the first 2 weeks, and basically they get more agitated, anxious. What I tell parents is if they're a little bit more ramped up starting this med, let it go if you can handle it. But if they're hitting people, let me know and we'll stop it. Again, when we look at are they safe or not? So far, the studies are showing they're safe for the growing brain. They really are. A lot of people are afraid of antidepressants, and they honestly, it's like Tylenol. Tylenol is probably more dangerous. Like they don't have any major harm that we found. However, depression in the growing brain, they've shown over and over again, it changes the brain. And imagine if you have depression as a little kid, it changes the brain permanently. So really, you can't ever just say, is this medication good or not? Is it dangerous or not? The question is always the alternative. Yes, if it's a mild depression and we don't ever have to, and you know, they're totally fine, but maybe they're down a little bit. Sure, try therapy first. That's okay for mild depression. Try lifestyle changes first. But at the end of the day, depression is going to hurt their brain more than the SSRI, and suicide is going to hurt way more than the SSRI. When do we stop the antidepressants? When there's a remission of symptoms for 6 to 12 months. Don't just leave the kids on them for forever. It doesn't mean you have to jump in and take them off, but you have the conversation at 6 to 12 months. Do we want to talk about coming off? That's how it works. However, if they've had multiple depressive disorders, if they continue to be suicidal, if they've been really treatment resistant, then you can still bring the conversation up, but say, you know, it looks like the research indicates you should probably stay on this longer. They don't need to be on it for forever. I always warn parents that. DMDD is a little bit different. We're still doing ongoing treatment, but right now we found the best way to treat DMDD is to treat the ADHD actually that usually goes with it, because it helps with the dysregulation. Otherwise, you can sort of pinpoint any main symptom. If they're aggressive, if they're dysphoric, you know, maybe a Risperdal, maybe an SSRI. All right, and I'm going to fly through this because we're almost done. What you can do for parents. Psychoeducation, it's amazing. By psychoeducation, I mean, all the stuff you learned here, tell them. It actually, the cool thing, let's see, is that, look, with psychoeducation, there is a 50% relapse rate. It literally can change and be treatment. Like it can change depression. Part of it is because of this cycle here. Sorry for my horrible copy job, but partially because there's a cycle, there's a vicious cycle with depression that happens where kids get depressed. They say, I don't know what this is. I don't know what's happening to me. I feel hopeless. Then they get more depressed and then they freak out more. And what happens is parents come to you and they're like, I don't know what to do. And if you can say, hey, this is what we see. This is what we know about the disorder. We know it's very responsive. That can help break that cycle, just that in itself. And the thing is, a lot of parents don't know what the signs of depression are. They maybe know like what a normal teen is, like, okay, kid sleeps too much. Is that depression? Well, not necessarily unless it's in the context of everything else. Normal for a teenager to sleep too much, but what about a teenager who sleeps too much, never goes out with friends, is failing school, is skipping classes? That might be depression. So it's important to talk to parents about this. What about if a parent disagrees with the diagnosis? I don't want to go into it too much, but what I do is I tell them, this is what I see at this time. It doesn't mean that, you know, let's say they think it's bipolar disorder. And I say, well, this is what I think at this time for these reasons. But I could be wrong, and I'm also up for monitoring, and I will see what happens in the future. I warn them a lot. I try and do a lot of system psychoeducation. The mental health world is confusing, probably for all of us. There are a lot of blurry lines. I do a lot of coaching of go back and talk to the therapist. How do you make an appointment? Things like that. Little things happen where we think they should just happen, but families don't know. For the prevention of onset or recurrence of depression, things we can do are stop the cycle. We talked about that. And then help the parents treat their own mental health problems. Parental depression makes a big difference in multiple different ways. School part, the school staff can, and I didn't have a ton on this just because it's not aimed at that, but offer support and encouragement, let them know when you see small improvements, encourage their interests, provide psychoeducation, remind them that it can get better. Something we can all do, if you ever want to take a look at the QPR website. It's CPR for suicide. It's not a therapy, it's just a treatment, but it has good evidence that is basically, how do you deal with someone you worry might be suicidal? The big thing is ask the question, are they suicidal? It's important to ask. And then try and set them up with resources. Try and tell them that you care. So little things that we can do. I know I'm just rushed through it. Just a summary is, so you can ask, are you depressed? Remember, that's a screener. Yes and I don't know are positive screeners, no is no. You can give a PHQ-9. You can interview and ask SIGI caps. Ask about suicide. Don't be afraid. It's important to talk about it. If they don't know, keep pressing and ask more. Are you suicidal now, or were you suicidal? It's much different if a patient presents with chest pain and they have chest pain and tingling in your office versus if they had chest pain 3 years ago and they're fine now. Much different workup, right? Provide psychoeducation. It's treatment in itself. It makes a big difference. So things that you learn on here, talk to them about it. Talk to them that depression is normal. It happens to kids and that it's treatable. We know how to treat it. Yes, there's some kids that other things happen that they aren't the perfect remission case, but more often than not, research shows most kids are going to respond and do great. Most kids are going to be able to come off SSRIs. And then consider your own views on depression, medications, and suicide and how they might impact your treatment. You can have your own personal views. You know, maybe you think medicines are stupid or something for kids who have depression. I would still say review the research and see if that aligns with your thoughts and why or why not. It's good to know that because this is a hot button topic. And finally here, the new crisis line 988, you can text. So we can give that out now more to people. The QPR I talked about, it's good to look up because it's very simple for professionals or just lay people. They have tons of trainings all the time, and it's very understandable. Here's some optional reading if you want to look up stuff, and we are done. Whew. Thanks everyone for paying attention. Hopefully you didn't have a heart attack there.
All right, thank you, Dr. Johnson. And we did get a few questions about whether we'll be sending out the slides. Yes, we will send a handout of the slides, so you'll have access to all the resources and information Dr. Johnson covered. And so we might have time for a couple of questions. Please put your question in the Q&A and we'll try to get a couple answered. All right, it's got some nice reviews here coming in. There was one question that came in, and this was one of the questions that came in during registration, but the question was, what are some unique features of teen depression, specifically in their sleep patterns or their routine? Because, teens have, there's different behaviors just with teens anyway, but what are some of those telltale kind of things to look for?
So yes, teens are moody and they break boundaries and they can be angsty. So you are going to look for an impairment in functioning or high distress. And I know a real impairment in functioning beyond what's normal. So let's say a kid is snappy and they maybe they take forever to get out in the morning, get out of the door in the morning. That's okay. But in combination of they suddenly are not hanging out with any friends and they're isolating all the time and they stop eating, or they went from sleeping a lot to sleeping all day and all night and skipping things, or you're worried about substance abuse. It's when it starts, the goosebumps come in and the hair on the back of your neck or whatever, you start feeling like something is wrong with this kid. It's not just about the actual symptom, it's about there's a change and it's the functioning or the distress tolerance has gone down. They're skipping school, they are lying about things, changes like that.
All right, thank you. Did you see the question come in? There was one that, or I can read it out.
No, I can do it. For a child presenting with DMDD symptoms, but also has a history of significant trauma, how would you diagnose it? Can they both be diagnosed? How would you tease out whether it's truly DMDD or trauma PTSD? Oh, that's a huge question at the very end. It's a great question, but this gets to a heart of psychiatry. So psychiatry is very behind with our treatment of trauma and attachment disorders and attachment trauma. So what I hope we get better. What I will say is, I personally, not everyone will say this, but I personally believe that most psychiatric disorders can be caused by trauma or at least turned on by trauma. What I believe in doing is treating the disorder in front of you, regardless of what caused it. The way I think of it is, if someone breaks their leg, you're still going to send them to PT. You're still going to get them maybe surgery. You're still going to get them supportive treatments, right? Like, you're not going to argue about whether or not their leg is broken. But how they got their broken legs, certainly that can make a difference, but we're still going to treat it the same. The way that I see it is, if we're seeing DMDD, yeah, there's a good chance there was trauma. If there's ODD, there might have been trauma. I mean, trauma is, they think that 50% of kids experience at least one major trauma and they have high ACEs and stuff. So the way that I treat it is I treat the problem in front of me. It's a little bit maybe concrete. So if a kid has trauma and now they dissociate all the time, but it looks like inattentive ADHD and it's getting in the way of school, yeah, I believe it's, I will call it inattentive ADHD and treat it. But I do believe that maybe it's trauma underneath. So that's how I try and tease out the different symptoms. PTSD in the DSM is not the same as trauma. This is the hard thing, is that PTSD is a very specific diagnosis, and a lot of kids who have trauma don't meet criteria for PTSD, but it doesn't mean they weren't traumatized. It's just the DSM does not do a good job with addressing trauma, to be totally honest. So for me, PTSD means flashbacks, nightmares, like hypervigilance. So I would say they can have DMDD and PTSD, but trauma is one of those underlying symptoms that once it gets to the point of a disorder, for me, we need to treat the disorder so things don't spiral out, regardless of if it was trauma, biological, medical, doesn't matter. So yeah, yes, you can diagnose both, but it's a much more complicated question and answer than that.
All right, thank you. Well, that's a good question to end on. Looks like we're at time. I want to thank everyone for attending. I'll just end with a few housekeeping announcements. This course was certified for AMA PRA Category 1 credit. Attendees are eligible to claim continuing education by completing the evaluation and attestation form and downloading your certificate of participation. The step-by-step instructions are included in the chat section. I'll also send this in the follow-up email. In closing, I just want to thank Dr. Johnson for such an informative presentation, and thank you all for attending. Have a great afternoon, everyone.
Yeah, thank you, everyone. I appreciate you sticking with me for this.
Bye.